ऐसी चला है.
So RX event good to go?
Yes, sir. We are live now.
Yeah. So very good evening, everyone, and welcome to no thrombosis program. And no thrombosis program is we have received the award from SIMS for most engaging scientific platform in any pharma companies in India. So no thrombosis program is is all about real life challenging cases of clinical cardiology, particularly related to the patients with CAD, PAD, DVT, pulmonary embolism, atrial fibrillation, COVID-19 coagulopathy. So I from behalf of MCure, I welcome to Dr. Praveen Chandra sir. And there is no introduction. This was not required for Praveen sir, who is well-known India's renowned doctors. And sir is chairman of division of interventional cardiology from Medanta, the Medicity Hospital, Gurgaon. And our today's moderator is Dr. Vinayak Agarwal sir. Dr. Vinayak Agarwal is head of Department of Non-Invasive and Clinical Cardiology at Fortis Memorial Research Institute. So welcome to Vinayak Agarwal sir. And next moderator is Dr. Tapisha Husser. Dr. Tapisha Husser is presently working as head and Department of Vascular and Endovascular Science in Manipal Group of Hospital in New Delhi. Welcome, sir. And today's our speakers are Professor and Dr. Digvijay Sharma sir and Dr. Yannar Shastri sir. So welcome, sir. Welcome from behalf of MCure. And also today's the next speaker is Dr. Abhishek Gupta and Dr. Ashu Gupta sir. Welcome to today's program. And today's agenda is that the first, the case will be presented by Dr. Digvijay Sharma sir on complex and recurrent DVT. And second case will be by Dr. Yannar Shastri sir. And third is Dr. Ashu Gupta. And fourth is Dr. Abhishek Gupta sir. So with this, I will hand over the sessions to Dr. Praveen Chandra sir. Please, sir. Please take, sir. Over to you, sir.
Okay. Thank you very much. I think it's a very interesting program which MCure is running. And it has great educational value all the time. Very short, very sweet. And with my colleagues, Dr. Sahu and Dr. Vinayak, they are so well versed with the the use of anticoagulant therapy, the newer anticoagulants or DOACs. So today we are going to discuss about both the peripheral use of this DOACs in peripheral vascular disease, use of DOACs in atrial fibrillation, and also the use of DOACs now, which is the new mode of therapy in coronary artery disease as a long-term therapy for especially in the view of use of these drugs in those patients where they are on chronic coronary syndromes. Okay, so we will start with the first presentation, which is primarily on prevention of DVT and those patients who have DVT or who have high chances of developing DVT. We will have the discussion, and I'm sure Tapish will have lots of things to say in that. And so we'll start with the first presentation. And can you just invite the first presenter?
Yeah,
and also introduce his credentials. That will be nice.
Yes. So I welcome to Dr. Digvijay, Professor and Dr. Digvijay Sharma sir. Sir, I request you to please take the session forward. And Digvijay Sharma sir is head and senior consultant and vascular interventional and surgery in Fortis Escort Heart Institute and Okla Road, Delhi, sir. Sir, welcome, sir, and over to you, sir.
Hi, Ravi. So I'll start immediately. Am I visible there, my screen?
Yes, sir.
Yes.
So today, my part will be the DVT things and how we do it in our institute. So I'll discuss two short cases. Now, case one is a 42-year-old male. He got an acute extensive DVT right leg. Acute by definition is less than 15 days old. So we took him up to the cath lab, posterior tibial vein access micropuncture kit, Craig McNamara to lace the thrombus with Acrylize. We wait for about 30 minutes. The prescribed time is 5 times the T-half of whatever drug you're using, urokinase or Acrylize, according to your preferences. Then we put the patient on prone position. and then get an Indigo Cat 8 system with separator. I had to do 2 passes, and I managed to get a class 3 license. Completion angiogram did show a CT of the right iliac vein with extensive collateralization, indicating a chronicity of that iliac stenosis, which was opened with ballooning and optimate 16 stent over the stenosis. We obtained an unrestricted flow to the IVC. I did not deem an AVF to be necessary because it was a very high flow system there. We could discharge the patient on POD3 on rivaroxaban for about 3 to 6 months. We give him 3 months and then review later. This is how he went. This is how we take a posterior access. We find it much easy to maintain for only CDT part. It's easy to press and the patient can move his leg very well. Contrary to if you take a posterior vein, popliteal vein access, very less painful and extremely comfortable to the patient. So our initial angiogram, we try to get it from the posterior vein. Surprisingly, they're easily accessible because they have engorged themselves because of a proximal block. We profiled the lesion. This is the extent of the amount of the thrombus that we saw. 2 passes, cat 8 removed. And the best thing I like about this Indigo system is you can actually show a nice patent functioning valve. That is the whole idea of doing a pharmacomechanical thrombolysis in the early part of the disease, like immediately the moment it comes in, acute extensive. Of course, preventing pulmonary embolism also. This was the stenosis. Now, because it's in prone position, it is reversed. The right side ulti taraf aa jayega, and unrestricted flow was obtained. Now, second case. Now, this is a 30-year-old female. Again, an acute extensive DVT. This is a postpartum state. Again, we take a micropuncture PTV lesion. She was a bit obese, so not easy for me to turn around. We took a 10 French sheath where the superficial saphenous vein in the short saphenous vein in the supine position was maintained. We took an angiojet Zelante and 2 passes. Again, very good clearance. Again, we got an stenosis of the iliac vein. In pre-procedural counseling, the patient did not want a stent. She was happy with repeated ballooning if required. And we ballooned it up. Not very good opening, but since we didn't have consent for the stent, I didn't go for it. Second post-op day, again could send her back right on the day of Holi to meet with her newborn child. This is the lady. This is the lesion profile. You see a lousy iliac vein, and we see there's no flow into the iliac system at all after 2 passes. There's a tight stenosis. This is the femoral clot burden. This is your Zelante angiojet system in place. Post thrombectomy, you see a streak onto the iliac vein stenosis. I ballooned it up to 12 and 14, 16. That was all I could get. No option for a stent because the patient was adamant कि मैं stent नहीं चाहिए. Fair enough, good decision on her part and a very wise decision. Again went home well and did well. Now, we have a protocol for DVT in our department. We always follow the Society of Vascular Surgery reporting standards. We have reasonable volumes and they have only thing they helped us is our prediction and our outcomes are more predictable now. So what we prognosticate, we are tend to achieving it as our volumes have increased over the space of 4 to 5 years. It gives a good feeling to be able to tell what is going to happen to you and that thing is achieved at the end of the procedure. So we have a DVT response setup. We have a quick fast track mechanism. If it is a suprainguinal disease, we will call it extensive. And if it is acute, less than 15 days, we have a bias for pharmacomechanical and very aggressive management in this condition. If it is a femoral and acute DVT, we are also be more aggressive if the patient is younger. Otherwise, we can just do CDT and get away with it. We generally prefer NOACs over warfarin if kidney function is good. My only indication to not give NOACs like rivaroxaban is if the patient is not having a good renal profile or some adverse drug reactions to the particular drug. Warfarin generally is not my first choice for DVT and its continued management and prophylaxis anymore. barring, I will repeat, renal issues. And thrombus is like the truth, always reveals itself. You should know when to treat it with respect and not touch it, and usually better we remove it, whether it is arterial or venous. Always patients will do well. Thank you very much.
Thank you, sir. Thank you. And over to Tapish sir and Vinayak Agarwal sir.
So excellent results, Digvijay sir. The only thing is that taking multi-axis, I mean, for the audience, I'd like to say that sir has said posterior tibial vein. He's now well versed with it. That's why he finds it easy. It initially has a learning curve that I should say that you need to be well versed with ultrasound Dopplers to know where to puncture, because lysis has one disclaimer that you cannot have multiple punctures. You have to be very sure about your axis, and that is what he has clearly demonstrated in his management of cases, that the posterior tibial vein axis, because of comfort to the patient, it's being more and more utilized now. Only one thing, Digvijay sir, that in the second patient you had multi-axis. One was a 10-inch sheath in the short saphenous, and one was a posterior tibial axis. So when you took out the sheath and continued your lysis, wasn't that an concern or an issue, sir?
This is a good question, because once we continue our lysis, we need to have 2 to 3 days of planned time period for the lysis to take proper effect. And I find that if you continue the lysis through a big sheath, it's distinctly uncomfortable for the patient to have that plonky sheath on your popliteal area. So I'm very happy to. A short saphenous vein is easily compressible. वो deep vein तो हुआ नहीं. So it was very easy for me to take it out and happy with it. I would avoid to take a popliteal vein puncture directly, just because of that reason, because I somehow find I'm very comfortable with the continuation of my lysis with a ankle access. You are right. It took me some time to learn, but धीरे धीरे ये pedal access जब आर्टरी में लेने लग गए अपन, तो मैं बोला उतना ही साइज तो वेन का है, तो क्यों काय को नहीं करना. फिर माइक्रो पंक्चर किट्स आर अवेलेबल, सो वो चला जाए. एंड वंस यू डू द अल्ट्रासाउंड, आई जनरली कम टू नो कि इसमें जा सकते हैं कि नहीं जा सकते. सो 90% ऑफ द टाइम यस, आई कैन गेट इट डन.
So basically, it is the planning of every case. It's a case-to-case basis. No two cases are alike. No two thromboses are alike. He has said that it reveals like the truth. But then planning, if you are not planning, then you are failing beforehand only. So you have to plan your access. You have to plan your multi-access. You have to plan your sheets. You have to plan your concomitant procedures. Like if you want to do just lysis, or you're planning for a balloon, or you're planning for a stent beforehand. You cannot be stuck in between that. Okay, I didn't plan it that way, and now you want a अब मैं क्या करूं, किधर से जाऊं. So this thing has to be learned from these two cases, that what he planned, he executed in the manner that was discussed with the patient in the best possible manner. That is a protocol that he has established based on the SVS guidelines, and that's very important. The second thing is what Professor Digvijay has said, that regarding the NOACs he prefers generally over the VKAs right now. VKAs do have a role. Dr. Vinayak has discussed this n number of times, even in the cardiac this thing. But routinely now it is being replaced by the DOACs. Only if the renal profile is quite haywire, then you cannot predict, and the patient may tend to bleed. That is where the vascular surgeon reserve their drug therapy on a case-to-case basis. Thank you, Digvijay sir. Vinayak sir, over to you, sir.
Yeah, one question for the Digvijay sir. Myself, Dr. Abhishek Gupta. Am I audible?
Yes, Abhishek sir. Yes.
Sir, how do you decide when to stent in a venous system when it is not May Thurner? So even then you give the option of stenting in every vein.
Usually, when I take up a case for DVT, for pharmacomechanical or any procedure, I have a CT venogram done already.
Okay.
फिर IVOC अपने पास रहता है. तो if there is a stenosis and it is an unprovoked DVT in the first profile, I would put that stenosis as cause. So I will definitely balloon it. ये पहले ही पता रह जाता है. We can tell the patient you have a stenosis there. Ballooning will be required. If it is young, I generally avoid a stent. It's not a good place to stent. I don't like venous stents unless necessary. Some patients are agreeable to stent, then stent only makes it look good for some time,
Yeah.
So ballooning tak to, if I have a stenosis diagnosed, I will say we should be prepared for it. And I also tell the patients that sometimes when I clean it up, I will find a stenosis, then at least something will be done to the stenosis. It won't be just left alone. Otherwise, you could have a recurrence. Then we have to follow them up. So yeah, उनको पूरी बात करनी पड़ती है, sir, with your team and with the patient. That's very important.
There is another thing, Dr. Abhishek, that as Professor Digvijay said, that you see upfront and get some clues. It is actually sometimes a profile of a patient who is having a left-sided iliofemoral DVT, and it gets unmasked. So as he has IVUS on his disposal, so if you have that, a routine venogram may not show any compression. But previously we were doing a balloon test. You used to inflate a balloon and pull it back. But now we have the IVUS at hand. If you find a cross-sectional area which is less and a left-sided patient, yes, in a young patient, if you have good results in a long term, because venous stents have a low flow system. Although that area, I mean, Sheshadri Raju normally puts 2.5 stents across the inguinal ligament, but we generally tend to reserve our stenting in that area for patients who have IVUS proven compression after unmasking of the lesion of left-sided DVT. It may also be right side, but mostly left side are the ones which are notorious for rethrombosis later on.
Thank you.
Yeah, by idea of presenting the first case was I got a right-sided with hurdles there. So दिमाग में रखना चाहिए कि वो right side में भी हो सकती है.
बरोबर, वो हो सकता है. The possibility has to be kept in mind.
Okay.
Vinayak sir, any comment, sir?
Yeah, I think it's an excellent case in depiction by Professor Sharma. And as you said that I think NOACs are going to be the mainstay of treatment going forward. And because of the safety profile and ease of administration, I think that's what it's going to be in such kind of patients. The only thing which I want to ask is that are we seeing a trend towards more and more venous interventions in DVT going forward? I mean, is it how do you actually assess whether it is aggressively needed or not? Is it based on the patient's symptomatology? What are your say? I would say class 1 indications for intervention in these class of patients.
This is a very pertinent question because we cannot do a procedure because we know how to do it. We should also give benefit to the patient after a successful procedure. These procedures do go wrong. So,
yeah.
अगर inguinal ligament के ऊपर है DVT, this has to be tackled. I would not sit on it. अगर if it is less than 15 days old, I would really aggressively go for it. इसमें तो बिल्कुल शक नहीं हुआ. Infrainguinal में अभी भी evidence based won't say that you have to be very aggressive all the time. In those conditions, if it is a young patient who can like manifest post thrombotic later on, then I would give them choices. भाई ये चीज हमारे हाथ में है, फायदा नुकसान दोनों का है. आपको लाभ होगा अगर आपका SFA ये थाई सेगमेंट knee to inguinal ligament में the thrombosis there, then definitely acute less than 15 years old, you can have a class 3 lysis, you can achieve very good results, and he is like his duration of anticoagulation treatment won't be reduced, but his complications of PTS reduces, and PTS is a hard truth. ये होता है.
I agree.
उसके लिए तो.
But thank you for sharing a very good case. Thank you for sharing a nice case. Thank you.
Thank you, sir. And so we'll go to the next case, Dr. Yannar Shastri, sir. Dr. Yannar Shastri, sir, is consultant and preventive and non-invasive cardiologist. He is from Mulchand Hospital, Delhi. Sir, welcome, sir. Can you share your case, sir?
Good evening to all my seniors. Good evening, Dr. Vinayak Agrawal, Dr. Digvijay Sharma, Dr. Tapi Shahu. I'll be sharing with you a case which we have recently done, in which the Shadwa score indicated use of warfarin. And in the follow-up, it was found that because the patient had less time during the time for therapeutic range, we had to switch him over to newer oral anticoagulants, and it had a much better result as compared to warfarin. So starting off with a case study. So we had a 72-year-old female.
Sir, just make full screen, sir. Yeah.
Yes.
Perfect, sir. Thank you.
So this was a 72-year-old female who was brought in the emergency with a complaint of left-sided weakness, which is noticed past 12 hours. She did give a history of dyspnea for the past 1 month, which was gradually getting worse. And by the time she came to us, it was NYHA grade 3. She was also complaining of giddiness on and off and generalized weakness. She had past history of hypertension, diabetes mellitus type 2, hypothyroidism, and dyslipidemia. And she was currently on telmisartan and amlodipine combination, linagliptin and metformin combination, atorvastatin, torsemide, aldactone, and monotrate. At the time of arrival, her blood pressure was 160/80 and her pulse rate was 124 beats per minute, and it was irregularly irregular. Respiratory rate was 28 beats per minute and her saturation was 94% on room air. On examination, she was having bilateral pital peding edema and bilateral basal crepitations in the chest, as well as S1, S2 was normal in the cardiovascular system. In the CNS examination, she was having left-sided weakness. The power on the left side was 2/5 as compared to the right side, and planters were normal, and she had no aphasia. On investigations, her CBC, urea creatinine, LFT were normal. NT-proBNP came back as 4500, and ECG revealed atrial fibrillation with fast ventricular rate. Patient was admitted, and in view that her she was having a late presentation, thrombolytic therapy was deferred, and she was put on conservative management with anticoagulants and other treatment. Bedside transthoracic echo initially done at time of presentation showed AF with FVR, mild LV dysfunction of 50%. She had biatrial enlargement and mildly raised pulmonary artery systolic pressure. Subsequent day after stabilization, patient was taken up for a transesophageal echo where although no obvious clot was seen, there was spontaneous echo contrast in left atrium and the left atrial appendage. A CT done at the time of emergency revealed a large non-hemorrhagic infarct in the right MCA territory, and a follow-up MRI revealed a right vertebral artery thrombosis. As TLT was deferred, patient was this thing. A Shadwa score was done, which revealed basically a score of 5/9, and a Hasbled score revealed 2/9. So patient initially was bridged with low molecular heparin, and later after titration was discharged home on warfarin with keeping the INR of 2.3 and advised to review with INR report. So initially patient was fine. After review of 3 months, patient again presented to the emergency, this time with a history of 2 episodes of transient ischemic attacks and once while he was driving. Luckily, he did not suffer from any, he was driving she was basically sitting behind a pillion rider with her grandson. Luckily, she did not suffer from any major trauma, just a few abrasions on the knee. So she was brought again into the emergency where a immediate CT was done, which showed no fresh changes. The MRI was normal and the ECG again showed AF with FVR. We readmitted the patient this time under neurocare where the INR was shown as 1.5. So on proper history, the patient revealed that she used to forget taking warfarin, or at times she used to take warfarin whenever she remembered it. So based on her history, it was revealed that the time in the therapeutic range was less than 50%. This time follow-up LFT and RFT were normal. And after proper counseling, after this thing, patient was put on rivaroxaban 20 milligram OD and sent home. We have been following up her after that regularly, and I think she came back 2 weeks back where her last episode, and there were no further episodes of thromboembolism. So in general, atrial fibrillation is basically a form of supraventricular tachyarrhythmia, and there is uncoordinated atrial activation and there is ineffective atrial contraction. So in ECG, basically you will have a irregular RR interval with the normal AV conduction. There will be no distinct repeating P wave. Mostly you will find fibrillatory waves, and there will be irregular atrial activation. So current classification of atrial fibrillation is of 4 types. The first diagnosed when he just presents with it. Paroxysmal, which lasts for 7 days irrespective of the treatment. And persistent, which goes beyond 7 days despite treatment or cardioversion, but less than 12 months. Long-standing persistent AF is those which is present more than 12 months. Chronic AF is no longer used as a terminology. In case treatment is being given, then it is called as long-standing persistent AF only. So the Shadwell score, which we used, basically consists of various clinical factors, and there is a score. The score is out of 9, and anytime the score comes more than 2, then it is considered patient needs oral anticoagulation. So the first one is congestive heart failure, which is any form of clinical heart failure with LV dysfunction. 1 point is given. Hypertension or hypertensive therapy, another point. Age 75 or more. The age is an interesting factor because if the patient is between 65 and 75, 1 point is given. And if he is more than 75, based on the age, what you call related risk, 2 points are given. Diabetes mellitus, whether controlled or uncontrolled, patient is given 1 point. Again, a history of prior stroke indicates a more, what you call risk, higher risk. So therefore, 2 points are given. Similarly, vascular disease is given 1 point. And then there is a category of females, which is a strong risk modifier. It is not a risk factor per se, but is a strong risk modifier. So in this case, the Shadwell score came to 5 out of 9, and therefore patient was started on warfarin initially. The Hasbled score, which is basically done concurrently with the Shadwell score, indicates a risk of bleeding, and you want it to be less than 2. So this patient, the Hasbled score was 2, so therefore patient was. So there are a lot of trials like Relay trial, Rocket AF trial, the Japanese Rocket AF trial, Aristotle, Engage. So the common factor in all of them is that in comparison with vitamin K antagonist, a standard 10A factor inhibitors are very safe and more effective in non-valvular AF. The landmark trial, which I'm saying, the Pocket AF trial, actually showed that the primary endpoint of stroke or non-CNS systemic embolism. So it showed that it was non-inferior to warfarin for the prevention of stroke or systemic embolism. So although there was no significant difference in risk of major bleeding, but ICH and bleeding were much lesser in the rivaroxaban group, although in a certain study, GI bleed was slightly more. So it is a very efficacious alternative to warfarin in high-risk patients with atrial fibrillation. In case those who are having a creatinine clearance of between 30 and 49, you might have to reduce the dose to 15 milligrams. But otherwise, it can be used very safely in a number of challenging clinical scenarios. So thank you, sir. That's my presentation.
Thank you, sir. And over to Vinayak Agarwal, sir, and Tapish Shah, sir. Vinayak, sir.
Yeah.
Good evening, sir.
Hi, Shastri. How are you?
Fine, sir.
So nice case, and I think what it has highlighted is very clearly the fact that in India it is nearly impossible to maintain, the INR values in TTR or in target therapeutic range, and NOACs are anyway. If you look at the main reason why we use the NOACs is because they decrease the risk of intracranial hemorrhage by 50%. That's where they score best among all the anticoagulants, oral anticoagulants. And because of the variability and so much of lability with food and other drugs, so NOACs are actually now class 1 indication in these cases. In fact, we do change. I have used even in mild to moderate, maybe not moderate, but when mild mitral stenosis, I've used NOACs where I know patient comes from remote areas, is not able to get decent, INR testing done. The only 3 contraindications to NOACs today are mechanical heart valves, the moderate to severe mitral stenosis, and bioprosthetic valves for the first 3 months after implantation, which most likely will change once the RIVER trial is published, where they've used rivaroxaban after 2 days of putting a bioprosthetic valve. So what we're seeing is a total change in the way we treat atrial fibrillation, valvular, or so the definition of valvular AF has changed. Everything which is aortic stenosis, even severe MR or AR with AF, anything which is valvular other than moderate to severe mitral stenosis is actually has come into the gamut of so-called non-valvular AF. I mean, they're treated as non-valvular AF. So virtually the NOACs have overtaken warfarin in almost every field. The other indications of warfarin which still remain are if you have a cavitary thrombus, for example, LV thrombus post-MI, or you have an LV clot, or patients who have APLA syndrome and have, say, clots elsewhere. So we still don't have the data, though there is strong data which is coming in where you can use NOACs even for LV clots. There are anecdotal, but it is not part of the guidelines. So these are the few extensions of where warfarin still holds edge over NOACs. Otherwise, in almost all fields, NOACs have replaced warfarin.
Yes. Thank you, sir. Thank you. I think, Tapish, sir, you want to add anything?
No, see, he's already said that it's a game changer. NOACs have taken over everything, and the usability still remains for the VKAs, but very limited.
Right, sir. So thank you, Enna Shastri, sir. Thank you so much. And we'll go to the next case. I think Dr. Abhishek Gupta, sir. Dr. Abhishek Gupta, sir.
Yeah.
Yeah. So the next case will go to the Dr. Abhishek Gupta, sir. He's a consultant interventional cardiologist from Ravindra Hospital and Heart Center from Hisar. So over to you, sir. Please share your case.
So good evening, everyone, and my senior colleagues. So this is a hypothetical case of anticoagulation leading to dissolution of LV clot. So such patients generally present in our OPD as being cardiologist, and 65-year-old male patient presents with anterior wall MI with late presentation window period of 36 hours and post myocardial infarction angina and dyspnea is the typical complaint. So Q-wave infarction, acceleration MI was there, and there was long-standing history of diabetes and hypertension. The patient was a non-smoker and no history of any CV or peripheral vascular disease. So coronary angiogram revealed 100% proximal LAD stenosis and severely hypokinetic anterior wall and apex with LV apical clot even on the second day, with EF being very poor. So patient undergoes percutaneous coronary angioplasty to LAD with drug-eluting stent. The patient is in sinus rhythm. During the angioplasty, of course, the caution has to be taken that the catheter shouldn't go into the LV at apex. And so medications and what I give is in such patient is DAPT along with anticoagulation. The anticoagulation usually I give is rivaroxaban 20 mg once a day, and along with aspirin and clopidogrel when NOAC is being used along with DAPT. So the data is only with the clopidogrel and aspirin, and rosuvastatin, beta blocker, SGLT2 inhibitor, and this ERNI, and of course MRAs and loop diuretics are given. So there are cases which describe post-infarction LV thrombus dissolution leading to with the combination of DAPT and rivaroxaban after 3 months. And in the prospective study of left atrial appendage thrombi, treatment with the rivaroxaban was associated with 41% rate of thrombus dissolution. So one more thing about the guidelines here. The guidelines now state that the NOAC can be used in LV thrombus and it should be used for 6 months. I think I have seen it in guidelines with ESC. So what is your take in this, that how do you manage the LV thrombus and post PCI patients?
Thank you, sir. Thank you. Thank you so much. And I think, sir, Vinayak, sir, you have any comments to?
So I think I've already discussed it, that, you know, even in LV thrombus, we are using NOACs in certain conditions, though it is not part of the guidelines, but we use it. And especially in a patient post-stenting, you do have the option of giving, NOACs with clopidogrel. So what a lot of people do is, so we know that when we combine NOACs with dual antiplatelet therapy, immediately say post stenting in a patient for indication for anticoagulation, the risk of hemorrhage goes up exponentially by almost 5 times. Now, whether you use warfarin with clopidogrel or you use aspirin, clopidogrel, and a NOAC, which is like called the triple therapy, or you use warfarin, clopidogrel, or aspirin. Now, all the triple therapies in the past have clearly shown that there is an increased risk of bleeding when you give them triple therapy, even if you give it for 1 month, and then quickly switch over to, say, dual antiplatelet therapy. When you combine a NOAC with clopidogrel, you are basically implementing what is known as a dual pathway inhibition. So you're giving a NOAC and you're giving an antiplatelet. So which is a very good combination theoretically, but it does increase the risk of bleed nonetheless. Now, usually I in my practice give warfarin with clopidogrel in patients who have had a stenting with, say, indication for anticoagulation, whether it is AF or LV thrombus. But if I feel that the patient will not be able to maintain INR in the therapeutic range, or if there is a contraindication to warfarin, then I will not hesitate to give NOACs like rivaroxaban in this case to this patient. I'm not sure if I would give triple combination to this patient to begin with. If the Hasbled score is nearing 3, then I think I would be all right to give these patients dual antiplatelet therapy to begin with. But if the Hasbled score is low, then yes, I can probably give triple therapy with rivaroxaban being given at 15 mg, aspirin and clopidogrel at 75 mg each. That's what I would say.
Actually, the main issue is that only in the post PCI patients, the NOAC as such would not act as antiplatelet. So DAPT, they can't be stopped at least for 3 months after post MI, and this is the real confusion that NOAC, they have to be given for the dissolution of the clot. So what is other take on this, that what should we do? We can't stop the NOAC at least for 3 months if the LV clot is there, and the PCI had to be done because there was persistent angina. And so
there are clear trials like Augustus and other trials which have shown that dual pathway inhibition even after your stenting is quite okay. In fact, if you see the recent trials of monotherapy, I mean, you can actually give dual antiplatelet therapy for a month and then start with just monotherapy after a month in a patient of high bleeding risk. The same concept applies to patients who have indications for anticoagulation. If you think that the patient has high risk for bleed, so the idea is not to underestimate the risk of bleeding, because bleeding has its own mortality, and you are pretty much so please remember that after 1 year of dual antiplatelet therapy, and if there is an indication for NOACs or OAC, you give only OAC after 1 year. It is not that they don't have an antiplatelet action. They do. They do have an anticoagulation and an antiplatelet action. However, stent thrombosis risk is real, but if you give them triple therapy, there is a prohibitively increased risk of bleeding in these patients, including raised intracranial hemorrhage and fatal bleeds. So it is a done thing to give dual antiplatelet therapy based on 3 trials which were published with each with rivaroxaban, apixaban, etc. So I think you have to choose. If the bleeding risk is high, you can very easily go with a dual pathway inhibition right from the beginning. If the bleeding risk is not high, you can start with maybe triple therapy with a slightly lower dose of the NOACs initially, and then just quickly go on to a dual pathway inhibition, removing aspirin. That's my take. I'm open to discussion from others, of course.
Yeah. Thank you, sir. I think any other comment from Dr. Digvijay Sharma, sir, or
I agree with Vinayak, sir, that it's a little, full dose anticoagulation with dual antiplatelet. I mean, even the Voyager trial had the arm of 2.5 PD, the dual pathway. If they went more than that, even in Voyager post-intervention to 5 mg, then also they had very high bleeding rate. So they restricted themselves to 2.5. So full dose anticoagulation with dual antiplatelets, yes, that gives you a peace of mind or no cirrhosis. But the bleeding risk is very real, and when the patient comes, they will not reach the hospital back when it happens. So that has to be kept in mind, right? He said.
Right, sir.
Yeah, I
sir.
agree on that line. The point is, once you are giving a full anticoagulant dose of NOACs, then adding further antiplatelets will increase your bleeding risk. अब ये आपने decide करना है कि वो bleeding risk is acceptable or not. It is going to be there. DIP at the low dose rivaroxaban and aspirin is a well established, very safe protocol. But a full anticoagulant dose doge and you want to add a dual antiplatelet to it, then you must really weigh your risks. There will be indications for that combination, yes, but वो सोच समझ के individualize करना better रहेगा.
Right, sir. So thank you, Abhishek Gupta, sir. Thank you so much for the presentation. Nice. And so we'll go to the next presentation by Dr. Ashu Gupta. Dr. Ashu Gupta is a consultant interventional cardiologist from Holy Heart, Rohtak, Delhi. So welcome, Dr. Ashu Gupta, sir, and over to you. Dr. Ashu Gupta, can you please unmute yourself?
Just a minute. Just sharing my screen.
Yeah. Please make it full screen, sir. Yeah.
Good evening to all my respected seniors. It is a privilege for me to speak in front of such a stalwarts of the cardiology. I will today discussing a simple case of CAD with PD and a house to be open to discussion that already been discussed for the third case. My case details were a 50-year-old male patient, care of chest discomfort on exertion with the CCS class 2 and history of claudication from 1 year. And there was no significant family history of CAD. Patient is in on-case of diabetes, was on OHA since 4 years and hypertension, well controlled. LDL was around 50. And with the patient history of ischemic heart disease with PTC and stenting to LAD 2 years back. And patient was compliant to treatment. And on this Doppler study, there was diffuse arthromatous disease of bilateral lower limbs with intermediate lesion of right internal carotid artery. ECG was normal sinus rhythm with LVH changes, echo mild LVSD with RWMA of inferior wall, and Doppler study diffuse disease of anterior tibial and posterior tibial vessel that was expected in diabetic patient. We done CAG that was stent in LAD was patent, but 95% discrete stenosis mid RCA and patient undergot PTC to RCA. Now, question comes, this was a case of chronic stable angina. Now it has occurred ACS. And before patient presenting to our hospital, he was on treatment with aspirin, rosuvastatin, metoprolol, and ramipril, ranolazine, and linagliptin, metformin in the required doses. So where the policymakers went wrong, that was the discussion in the previous case also. What went wrong and what we can do more for this patient? As the patient has experienced one cardiac event 2 years back and second event in the time frame of 2 years. One was ACS and second is chronic stable angina and with a coronary significant 95% RCA disease. Rivaroxaban in acute coronary syndromes, we have a COMPASS and an ATLAS, but where we are headed. COMPASS trial and ATLAS trial, that COMPASS also use the ATLAS trial doses. In the background of these all trials, REACH registry that shows that with every risk factors, the risk for recurrent MI and the risk for diffuse atherosclerosis increases. That increases with prior ischemic event more than 1 year, around 17.2%. Or if it is occurs in the less than 1 year, it increases to 21.1%. So what is our patient is also on the accurate lifestyle, smoking cessation, weight control, psychosocial support, and what we more can do. Lipid-lowering agents, patient with adequate dose of statin, izatimib, blood pressure control, we can do ACE inhibitors, ARBs, and for tight glucose control, we have DPP-4 inhibitors, SGLT2 inhibitors. Now the question comes antithrombotic protection. Such patient with chronic stable angina, as discussed in the earlier by all the seniors of the cardiology, that they should be put on this dual pathway inhibition. that because every platelet or every MI that occurs with the plaque rupture that initiates and propagate and fibrin formation is an end product of all this coagulation pathway. When there is a plaque rupture, the tissue factors comes in with the factor 7A that converts 8 into 8A and 9 into 9A and ultimately 10 into 10A. And ultimately fibrin formation occurs. Every drug acts at a different level. With this propagation is maintained by or inhibited by rivaroxaban and factor 10A inhibitor. And this propagation, if we block this propagation of the plaque rupture or plaque thrombus, then it's theoretically possible that we can prevent the future cardiovascular events. And with the ECS 2019 guidelines for the management of chronic syndromes, adding a second antithrombotic drug to the aspirin for long-term secondary prevention should be considered in patients with a high risk of ischemic events and without high bleeding risk. It's a class 2A and level of evidence is A. And high risk is defined as the diffuse multivessel CAD with at least one of the following: with diabetes mellitus requiring medication, recurrent MI, PAD, with CKD with EGFR 15 to 59, and moderate ischemic is defined as at least one of the following, that is multivessel diffuse CAD, diabetics, recurrent MI, PAD, heart failure, CKD with EGFR 15 to 59. Now this acute phase, our strategy is preventive study that we give DAPT. Duration can be variable, as a recent trial has showed even 1 month, 3 months, 6 months, and prolonged DAPT duration of 12 months. But because most of the platelet activation is strongest in the acute phase, in the chronic phase, we can shift patient on the single antiplatelet or dual pathway inhibition that has already been discussed in the previous case also, because it is a thrombin that perpetuate and that occurs in the chronic phase that may underline the pathogenesis for the recurrent cardiac events. There were various trials that gives Capri trial, Charisma trial, Pegasus and Pegasus 3. But it was the Compass trial that was a land-breaking trial that gives the concept for this dual pathway inhibition. All trials were given either remove aspirin and adding the most potent P2Y2 inhibitors. But this was the one of the trial that gives us dual pathway inhibition concept, that if we can break down or we can stalwart the generation of the thrombin, that we may halt the progression of this atheromatous disease. And because it decreases the 24% of the cardiovascular death, stroke 42%, and MI in 14%. Compass is the only antithrombotic revenue showing significant reduction in all-cause mortality, because Pegasus 3 and Pegasus 4, they differ in the P2Y2 inhibitor of dose of ticagrelor 19 and 60. In this Compass trial, inclusion criteria was previous MI within last 20 years, that was CAD for CAD patient, multivessel coronary artery disease with symptoms or history of stable or unstable angina, multivessel PCI, multivessel CABG surgery. Patient with CAD must meet at least one of the following, that is age more than 65 years or age less than 65 years, plus atherosclerosis more than 2 vascular beds or more than 2 additional risk factors like current smoking, diabetes mellitus, and EGFR less than 60 milliliter, heart failure or non-lacunar ischemic stroke more than 1 month earlier. For the PAD patient, definition of this was previous revascularization, previous limb or foot amputation for arteriovascular disease, or history of intermittent claudication, and one of the following, that is ABI less than 0.9, significant peripheral artery disease, documented angiography or by the duplex ultrasound, previous carotid revascularization or asymptomatic carotid stenosis, that was in our case more than 50%, as diagnosed by duplex ultrasound or angiography, or CAD plus low ABI less than 0.90. It was a randomized placebo parallel double-blinded trial around 27,000 to 325 patients. There were 3 groups: rivaroxaban 2.5 BD plus aspirin, rivaroxaban 5 mg BD or aspirin. There were decrease in MACE by rivaroxaban and aspirin combination by 24%, net clinical benefit by 20%, and decrease in mortality of 18%. But there was no benefit of rivaroxaban alone or aspirin alone. That gives the concept for the dual pathway inhibition. With the subgroup analysis in the PAD patients, major adverse events and major adverse limb events, they were also prevented by this rivaroxaban plus aspirin, that is 1.5%, and MACE was prevented in 5% cases. And of this sub-cohort of this Compass trial, 7,470 patients having the peripheral artery disease. And for this major adverse limb events and major adverse cardiovascular events and major bleeding, there is also significant reduction, although P-value was not significant. And for this peripheral vascular risk, they were used 2 scores, the REACH score and the CART score. So by this message from the Compass trial, switching from the dual antiplatelet therapy, that is dependent on the cardiologist. For what duration the treating physician or treating cardiologist they want to give DAPT. As the recent trial and with this COMPASS trial, if the patient with the chronic stable angina or chronic stable coronary artery disease or chronic coronary artery disease, they should be, after 1 year, they should be shifted to dual pathway inhibition if the bleeding risk is low. Thank you. So house is open for the discussion, because as in my case, patient was of chronic stable angina with ACS, and the house is open for discussion that what treatment is all my seniors are practicing in their real world scenario. Thank you.
Thank you, sir. Thank you. And over to Vinay, sir.
So I think that's a very well presented case with, I think you've already covered, Dr. Ashu, most of the aspects that were needed to be covered. In fact, I did mention, so see, COMPASS trial is a landmark trial in a way in a patient of CAD with PAD. The whole concept is that wherever you have a polyvascular involvement, then instead of having the conventional dual antiplatelet therapy, we should switch over to a dual pathway inhibition, is what COMPASS trial, which came in 2017, but unfortunately was never really appreciated for its concept till now. So very few people actually use aspirin 75 mg with 2.5 mg of rivaroxaban twice a day, but it's an excellent drug. It's an excellent combination, and I've seen very few side effects or bleeding risks with that combination. I've even given it to a lot of patients in the age group of 75 or 80. So it's not that it is dangerous to give it. Yes, you have to be cautious, but it can be given in these set of patients. Having said that, yeah, sorry.
Yes,
please.
sir. When the ACS patient, just like this patient, he was chronic stable angina. Now he has occurred ACS. There were two trials.
Yeah, so
there were two trials. I think
COMPASS trial is, sorry. Yeah, please go on. Yeah.
Sir, role of rivaroxaban or oral anticoagulants. There were, I think, two trials: APPRAISE 5 and Atlas ACS 251 that use rivaroxaban and apixaban in ACS patient.
Yes.
Sir,
that was a dose-determining trial.
Yeah. Sir, I just want to ask, is there any difference ACS patient that put on angiography done or PCI or chronic stable angina? If patient occur in second event of chronic stable angina, so there is a role of rivaroxaban in acute setting also?
No. So if you look at the trials, we don't have a single trial in acute coronary syndrome with NOACs. If you use NOACs in acute CS, it is basically an extrapolation of the concept, but we don't have a trial. Atlas, Timmy, was actually a dose-determining trial where they showed that 5 mg BD was actually showing much higher bleeding risk without decreasing the thrombotic risks. So they shifted to 2.5 BD, and it was just a dose determination trial. However, there is a subset of patients who will continue to have thrombotic events despite being on dual antiplatelet therapy. And in a lot of these patients, we do give them PCSK inhibitors. We bring down the LDLs to below 30 in a lot of these cases. As far as the antiplatelet or anticoagulants are concerned, we don't have the data, but if you feel that either they have a clopidogrel resistance, we shift to, say, you can shift to one of the prasugrel or ticagrelor combinations. Even despite those combinations, if the patient continues to have an aggressive disease and has events, acute coronary syndrome events, then you are within your rights to shift over to a dual pathway inhibition. The only problem is that COMPASS is a chronic coronary syndrome trial, not an acute coronary syndrome trial. So maybe the dose which you would be requiring will be a higher dose, say 15 mg of rivaroxaban with 75 mg of aspirin, but we don't have a data to substantiate it. So we look for reasons. Suppose they have a paroxysmal AF, my whole concept becomes easy, because then I can simply put them on a NOAC. However, at the present moment, we cannot advocate it. It will be left to the judgment of the treating doctor. but that's a difficult area to get into. We don't have the data to give in acute coronary syndrome.
Okay, sir.
So, Dr. Vinayak, one query. I mean, in all the, the talks that you're telling is that 15 mg of rivaroxaban with 75 of aspirin. So, I mean, not 10, not 20, 15 is the key that you are banking upon. I mean, either 10 is prophylaxis or 20 is a treatment. 15 BD is for 3 weeks to initiate the treatment. So now, why not prophylaxis if we are having that, and why 15 mg is your dependable choice?
So, see, the thing is that 15 mg is only recommended for patients who have an acute, who have a renal dysfunction where the GFR is low, say below 60, and we will give it, we can give it up to say about 30 ml per minute of the GFR that you're comfortable with. In fact, for most of these patients, 15 mg is the recommended dosage. What I'm trying to say is that if you look at the trials which have been done, like Augustus, etc., these the dosages have been on the lower side. I mean, you combine 20 mg with full dose of aspirin, the bleeding risks goes up. So 15 mg is something which has been tried and has been shown to have a lower bleeding risk. But you could go for a 20 mg rivaroxaban with 75 mg of aspirin. I don't think that should really make a difference. But somehow I think I'm more comfortable with that combination of 15 plus aspirin. And there are trials to support that.
Right. So, I mean, it was always established that 10 mg is the prophylaxis, but somewhere in between we are bargaining towards a risk-benefit ratio, and also dose adjustment, right? We said that for CKD, right? But I mean, we may need more data on that to say 15 is.
Yeah, we do. We need more data on that because we just have one single trial at the present moment. Yeah.
Right.
So I think any Digvijay sir, any comment from your end?
No, we are basically PAD people. So for me, it is always 2.5 rivaroxaban BD and 150 aspirin OD. All patients, preferentially all the time, for if possible for life. अब उसको ACS हो जाएगा तो is not going to come to my clinic. He's going to go to the cardiologist. I have limited knowledge on those lines.
Right, sir. Right. So, so with this, I would like to say thank you so much to all our speakers today, and also I would like to say thank you to Dr. Praveen Chandra sir and Dr. Vinayak Agarwal sir, Dr. Tapish Rao sir, and our today's very eminent speakers, our Dr. and Professor Digvijay Sharma sir, Dr. Yannar Shastri sir, Dr. Abhishek Gupta sir, and Dr. Ashu Gupta sir. Thank you so much from behalf of MQ. I would like to say once again thank you so much, and definitely our all delegates. Today's all our delegates got a lot of insights. Specifically, we have covered all aspects. We have covered DVT. We have covered the LV thrombus, CAD, PAD. So it was really very good benefit for all our delegates today, those who joined. So once again, thank you so much from behalf of MQ to all our speakers and all our faculties. So thank you so much. With this, we will close this session. Before closing the session, we'll play one video and then we'll close the session. Thank you so much.
Thank you, sir. Thank you.
Yeah, RX event, you can play the video.
Do you know which Indian pharma company has consistently launched innovative first in India products? Presenting MQ Pharmaceuticals. With over 500 scientists, we are pioneers in chirality. We have been making a healthy difference to countless families. With cardiology at our heart, we have strived to give you better products always. Chiral products are complex to develop. They are difficult to manufacture, but their benefits make a difference. A difference for your patients, for you. We are proud to launch our latest chiral development, Exafib, our indigenously developed rivaroxaban. developed in-house, manufactured at our state-of-the-art facility at Jammu. This is a WHO GMP certified facility. We conduct quality checks to ensure only the best is delivered. Exafib complements our chiral cardio portfolio. Exafib, committed to make a difference in anticoagulation therapy for your patients.
Very glad to inform all our delegates here that Exafib is #1 brand in all India and is well accepted brand, specifically for polyvascular disease, specifically in CAD and PAD patients. So I do request all of you to prescribe Exafib for in the management of CAD and PAD and DVT and pulmonary embolism, and also in stroke prevention in atrial fibrillation. Thank you so much for once again for all our delegates who joined and also our faculties today's program. So thank you so much and good night. Thank you.